Hi guys. I think I'm alone here, so no need to wear mask lah. Okay. Let me see. Okay. So today we'll it's lunchtime, right? Just after lunchtime. So again, another small dim sum for to sate your appetite. A short meal, a short snack. We prefer to call dim sum rather than the Western version, which is order tapas, right? Okay. So anyway, another 1 more minute, we'll start. Actually, I managed to do a bedside tutorial today, which without breaking any rules. So I'll be sending you the video later. But I still felt that I should maintain the tradition of meeting at least some of you every Wednesday, at least for a few minutes. Okay. So Cecilia, I see you there. Your name is there. You can hear me, right?
Yes, Prof.
Good. Okay. So I'm going to share screen now, and then we start. It's okay if the others can't make it, or I understand some of them are going for swaps and all that. Okay. So last week we ended off with a short discussion, and then we ended off with a trailer saying we'll continue just like any Netflix series. The next episode will always start off with some recap of what we already done, right? Okay. So what did we do last week? Basically, we understood why this man's nystagmus is considered peripheral nystagmus and what is the pathophysiological basis for it. And to understand that, we introduced these instruments, 2 eggs and 2 spatulas for you to understand eye movements. So we said if the person is asked to look to the left, you draw two X and then the two arrows. And then basically you connect up the arrows. One arrow is the lateral rectus muscle connected to the sixth nerve. This is the medial rectus muscle connected to the third nerve. Okay. And then because this guy is in the midbrain, this guy is in the pons, you need to connect these two up by using an escalator, and the escalator is called medial longitudinal fasciculus. Okay. So medial longitudinal fasciculus, right? So basically now if you activate this guy, the current is going to go down, make this guy abduct this eye. And then from this guy, the current goes up the escalator to the third nerve in the midbrain on the other side, and the patient is able to AD that. Okay, maybe I just pause at this moment and tell everyone to just check that you're muted. I think there's one person still not muted. Huh? Okay, good. So basically, so that's what happens, right? So then we also said that this is a reflex movement. So for this to be affected by volitional control, the volitional control comes from the frontal eye fields. The frontal eye fields. So the frontal eye fields will then send signal to the contralateral sixth nucleus for this to be affected. Okay, so that's what we said. Then we said that if we were to now look at my face on the video, if I'm moving my head left and right like this and vigorously disagreeing to this statement, okay, my eyes are still fixated on you, but my head is moving left and right. The reason why my eyes are still fixated on you is because of a reflex called the vestibular ocular reflex. And we worked that out, right? How do we work out the vestibular ocular reflex? We said that if my head turns to the left, my right eye is abducting and my left eye is adducting, exactly like this picture is showing. And this is due to a stimulus that's coming from the left semicircular canals, because when I turn my head to the left, the swishing of fluids, the endolymph within the semicircular canal, is much more profound on this side, where the head moves and stops, where the eddy currents are much more vigorous, just like waves crushing on the beach. Okay, the waves are moving and then they crash on the beach, so there's going to be more turbulence here. So this turbulence will then be sent through the contralateral sixth nucleus to activate the right lateral rectus muscle, okay, and through the medial longitudinal fasciculus for the left medial rectus muscle, okay. So basically this is the vestibular ocular reflex. So we told you last week that you don't need to memorize it. All you need to do is do the vestibular dance, and that will tell you straight away. So just to make sure that everyone learns this vestibular dance, you can all now think about, if you can do it in front of the screen, that'll be good. But basically, I want you guys to think about the semicircular canals on both sides. If I were to now turn my head to my right, okay, my left eye is automatically abducting and my left eye is automatically adducting, because my sixth nucleus on this side must be working. But where was the stimulus coming from? Well, if you can see, if I move my head suddenly like this, obviously the swishing will be more on this side. So greater swishing on this side, this signal is then sent across to the left sixth nucleus, and from the left sixth nucleus, the signal is then sent to the left lateral rectus muscle, and through the medial longitudinal fasciculus to the right medial rectus muscle. Okay, okay. So this is what's happening. Okay, everybody okay with that? Okay. So then we decided that if we were to mischievously come and damage one side, what will happen? Basically, if I were to damage one side now this side, both sides are firing at a basal level, which increases when I turn my head left and right. But if I were to suddenly damage one side, the remaining side is still firing, but at a basal, BASAL, basal rate. So this basal rate, as far as the brain is concerned, is going to be perceived as the head turning to the right. But when my head turns to the right, what happens to my left eye? Abducts, and my right eye adducts. But now actually my head is not turning to the right. Just that the imbalance in the ear is going to make my brain think that my head is turning to the right. So my eyes will straight away move as if my head is turning to the right. So my eyes would drift to the left. Okay, both eyes would drift to the left because of this mechanism here. Okay, and when that happens, what happens? Because I'm conscious and I want to look at you, I don't want my eyes drift to the left. What will happen is I will bring it back, back to the center. But the moment I bring it back to the center and I think everything is dandy, the imbalance comes back again and it's going to push it back to the left again. Then I get upset because I don't want to look at the wall. I want to look at you guys. So I bring it back again. And then it drifts back to the left. I bring it back again. I drift back to the left. Bring it back again. Drift back to the left. Bring it back again. This is what we discuss is the mechanism for peripheral nystagmus. Okay. And using this diagram, we straight away worked out all the key characteristics of peripheral nystagmus. Firstly, it's unidirectional because the imbalance is always on one side over the other. It doesn't matter whether the patient is looking up, looking down, looking straight, looking right, looking left. It's always going to be in the same direction, non-direction changing. Okay. And you notice just now when the disease was on my left ear, the correction, the fast component is back to the center towards the right. So the fast phase of this nystagmus is always away from the site of pathology. And because the semicircular canals are tilted like this, when you damage one side, the other three semicircular canals are firing unopposed. Because they are unopposed, what will happen is the nystagmus, the movement of the eye is going to follow the vectors that are resolved from the direction of the three semicircular canals. But because one semicircular canal is going up, one is going down and below, these two more or less cancels out. Okay, the only one that is truly unopposed is the horizontal canal. So you're not surprised that peripheral nystagmus is predominantly horizontal, but it's not completely horizontal because the semicircular canals from the top and the bottom are not diametrically opposite. They are slightly tilted. So they also contribute a little bit. And that contribution makes the nystagmus slightly rotatory. So mix horizontal and rotatory. And finally, the so-called Romberg sign of the eye, which is basically when you close the eyes or remove visual fixation, the nystagmus gets worse. So it's similar to the Romberg sign in the limbs when a person comes into the room walking normally, but the moment he closes his eyes, he starts falling. Okay? Okay, so with the eyes open, the nystagmus is not so prominent. With the eyes closed, the nystagmus becomes much more prominent. So this is Romberg sign of the eye, another sign that this is peripheral nystagmus. But we said that it's not practical to ask patients to close the eyes all the time. And that's why we have glasses like this. I can show it to you, the one that I'm carrying in my hand. Okay, so this is the thick magnifying glasses that we use on patients. So it's so thick that if I were to put it on myself now, if you look at the screen, you notice that I'm not able to see very much, but you are able to see my eyes very well. Okay, so this is the thick magnifying glass that I'm using. With the thick magnifying glasses, I can remove the visual fixation and still able to see the patient's eyes. For example, here, with removal of visual fixation, the nystagmus is very prominent, but when she's looking straight without the glasses, the nystagmus goes away. When the removal of visual fixation, the nystagmus is much more obvious. With visual fixation, the nystagmus is suppressed. Okay, so like Romberg sign, whenever you remove visual fixation, then or make the person unable to see, the nystagmus becomes much more obvious. Okay, Romberg sign of the eye. So like this, the same thing here. Right? So nystagmus that becomes more obvious when he's putting on the glasses and the patient is not able to see. When you remove the glasses, the nystagmus is very, very subtle, almost disappears. Okay, so this is peripheral nystagmus. So this is all we did last week, most of what we discussed. So now for the new episode, okay, we left behind this trailer to say that, okay, if that is peripheral nystagmus, how do you explain this lady's central nystagmus, which is completely different? When she looks to the right, it beats to the right. When she looks to the left, it beats to the left. So it seems to be quite different from the other nystagmus. So this is known as the classic form of central nystagmus, which is the horizontal gaze evoke or gaze dependent nystagmus. So how do we work that out? Okay, basically, just now we said that the frontal eye fields are responsible for making the eyes move left and right volitionally. But before the frontal eye fields can work, they have to stop at an intermediate transformer station called the PPRF. So basically what the PPRF does is move the eyeball with some force so that the eyeballs can start accelerating from zero velocity to maximum velocity. Because if you look at my eye now, if I would move my eyes from your looking at you to the side, now you notice that the eyes are moving so fast. Now this is like starting a car from zero velocity. You know that your car needs a first gear. Okay, so the first gear is what PPRF provides. Okay, another way of looking at it is PPRF is where the command to go there appears. Okay, go there. Okay, so I call it the go there neurons. Okay, now once the eye starts moving towards the direction, then once it reaches the direction, okay, because the primary position is the position of rest. Now, once the eyeball reaches the position, it needs another set of neurons to allow the eyeball to stay there. Okay, so there are two sets of neurons, the go there neurons and the stay there neurons. The technical terms for them are a little bit tricky. Okay, they are called neural integrators and burst neurons. But for practical purposes, for the clinicians, we just need to remember that there are two sets of neurons to allow the frontal eye fields to act on the 6 nucleus. One is the go there neurons and one is the stay there neurons. Now, the go there neurons are in this nucleus called the PPRF, okay, which is a pre-nucleus that takes the command and winds it up to first gear. But after the eye starts moving, a second set of neurons, the stay there neurons, are coming in to keep the eyeball where it's supposed to be. The stay there neurons are in various nuclei within the brainstem. Some of these names are a little bit tricky. Okay, like for example, the nucleus prepositus hypoglossi. Okay, sounds like a Harry Potter charm, isn't it? Okay, you can almost see the things levitating in the room. Okay, so these names are kind of tricky. You don't need to remember them, but just need to know that they are dispersed throughout the brainstem. So if one of these structures are affected, then the stay there neurons are gone. But an easier thing to remember is that the whole of the cerebellum has got large number of stay there neurons. The cerebellum has got large number of stay there neurons. So what you need to remember in the second dim sum is that central nystagmus is due to pathology in the stay there neurons. Remember that, you need to memorize this, unfortunately, okay? Because so far, everything we have worked out is more or less, you can work it out based on the vestibular dance and the diagrams, right? But the idea that the central nystagmus is due to stay there neuron pathology, you kind of need to commit to memory. Okay, so let's simulate what happens to this patient when the stay there neurons are affected. Look, the frontal eye fields is telling me, okay, come on, both eyes, look to the left. Look to the left. So my frontal eye fields will send a signal through my PPRF to my 6 nucleus, right? These are all working well. So my eyes are able to start moving. Once it reaches the target, okay, it reaches the target, but the stay there neurons are faulty. So what's going to happen? Slowly starts drifting towards the center. And then I'm thinking, oh my God, I wanted to look at the wall. Why am I still looking at the computer screen? Let me do another signal. So my frontal eye field sends another signal to the PPRF, and the PPRF pushes the 6 nucleus, and therefore the eyes will go back to the position again. But then once it reaches the target, because the stay there neurons are not working, what happens? Slow drift comes back again. And then again, I'm quite upset because I wanted to look there. So what do? I push it back again. Quick one. Okay. But then it drifts back again towards the center. Fast component, slow component. Fast component, slow component. Now I get tired of this nonsense. I'm sick and tired of looking to the left because my eyes keep coming back to the center. So why don't I change my mind and look towards the other direction? So my left frontal eye field sends a signal to the other PPRF, and the other PPRF sends a signal to the 6 nucleus. But my cerebellum is still poisoned by the alcohol that I drank last night. Okay, cerebellum is completely screwed. Okay, so no stay there neurons. So what's going to happen? My eyes are reaching the target. okay, reach the target, but the stay there neurons are not working. So what's going to happen? Drift back to the center, right? So again, I send a signal from my left frontal eye fields to my right 6 nucleus. I push it to this side. It reaches the target, but because my cerebellum is not working, it's going to drift back towards the center again. Stay there, neurons are not working. It's not able to stay. The eyes are not able to stay where it's supposed to stay. Now I'm completely disillusioned looking left and right. So I decide look up. Okay, once I look up again, my go there neurons are working perfectly. I'm able to reach the target. But because my stay there neurons are not working, what's going to happen? It's going to start drifting towards the center again. Okay, now I decide, okay, let's look down and see what happens. Again, my go there neurons are working perfectly. So I'm looking down. But the moment I look down, my stay there neurons are not firing. They're going to make my eyes drift back towards the center. So I get tired and I say, look, let's go down again. Boom, I bring it down and then it drifts back to the center. Boom, I bring it down and it drifts back to the center. Boom, it brings back. Now it's beating down. So in other words, when I look to the left, it's beating towards the left. When I look to the right, it's beating towards the, when I look to the right, it's beating towards the right. When I look up, it's beating up. When I look down, it's beating down, right? So in other words, okay, every time, any direction that I look at, the nystagmus is in that direction. So for those of you still a little bit confused, let's just do it one more time, okay? So now I decide to look to the right. What happens? I'm able to look to the right, fast component, right? But then because my stay there neurons are not working, it's going to drift back towards the center. So I push it back, fast component, drift back to the center. Push it back, fast component. And remember, nystagmus is defined by the fast component. So now the nystagmus is beating towards the right in the direction of my gaze. Okay, when I looked up, okay, again, fast component up, but because the stay there neurons are not working, it's going to drift back to the center, down. Now push it up, down, push it up. So it's up beating now. So when I look up, it's up beating. When I look down, it's down beating. So it is gaze dependent or gaze evoked nystagmus. Both names are very nice to explain. Why? Because things happen only when I evoke the gaze. When I look straight, nothing happened, right? When I look straight, nothing happened. But when I look up, look down, look left, look right, you have a nystagmus that is gaze evoked by the gaze, and it's gaze dependent. It is in the direction of the gaze. Look to the left, beats to the left. Look up, beat up. So this is the basis of central nystagmus. And it is quite different from the peripheral nystagmus, right? Because peripheral nystagmus is unidirectional, number one, never changes direction. Okay, it's mixed horizontal or rotatory. Number two is fast component, always away from the site of pathology. Number three is mixed rotatory horizontal. Number four, it disappears when you open the eyes. When you close your eyes, it appears, becomes more severe, correct? But in this case, just like any Romberg sign, if the person has got cerebellar disease, he's going to be unsteady, whether his eyes are closed or open. So we don't even do a Romberg sign when there's peripheral, when there's central cerebellar disease. But when a person has a peripheral disease and comes and says, doctor, I'm unsteady, but the eyes open is fine. Eyes closed, it falls. We call it Romberg's. So the same way Romberg sign of the eye applies for peripheral nystagmus, but in central nystagmus, whether the person's eyes open or closed, it doesn't seem to make a difference because the cerebellum itself is faulty. So it's not able to suppress the nystagmus with visual fixation. So eyes open, eyes closed, with the glasses, without the glasses, the nystagmus looks the same. Okay. So this is a classic example, a patient with cerebellar disease, looks to the right, beats to the right. Looks to the left, beats to the left. Okay, so quite different from the nystagmus that we saw, like in this lady and this man, right? It is unidirectional nystagmus, never changes direction and worsened by removal of visual fixation. This one is a pure horizontal nystagmus. Direction changes. Nothing happens at primary position. It only happens when she evokes the gaze. And it's always in the direction of gaze. When she looks to the right, it's beating to the right. When he looks to the left, it's beating to the left. And this lady has got cerebellar degeneration. This man has got, unfortunate, a man has got Wernicke's encephalopathy. Again, a very important cause of cerebellar disease. Very easily treated with high doses of IV thiamine, but this one, I think we all missed this diagnosis and he ended up with quite significant damage to his brain. You can see that when he looks to the right, the nystagmus is beating to the right. Okay. Now, if I were to get him to change his mind and look to the left, the nystagmus also changes his mind and starts beating towards the left. So again, classic peripheral nystagmus. Okay. If I can persuade him, he's a little bit confused, confabulating away. Persuade him to look up. I'm trying to do that. He will start beating up. When I ask him to look down, he will start beating down. So all in the direction of gaze. So classic gaze evoke or gaze dependent nystagmus. And what is the pathophysiology? Stay there neurons are affected. And the stay there neurons are largely distributed in the cerebellum. So you're not surprised that cerebellar disease is very commonly associated with gaze evoke or gaze dependent nystagmus. But some nuclei, individual nuclei, are distributed in the brainstem, are also responsible for stay there function. So you're not surprised that in some brainstem disorders like lateral medullary syndrome, you can catch one of these nuclei and end up with a very nice gaze evoke or gaze dependent nystagmus. But many times in brainstem disease, if none of these nuclei are affected, you may not get this classic central nystagmus. Okay. Now, there are other forms of central nystagmus, but they are super rare. Okay, downbeat, upbeat, pure torsional, and pendular. So the main central nystagmus that you need to learn is horizontal gaze evoke nystagmus and how you differentiate it from peripheral. Why is it important? Because this is another localizing tool. So if you see a patient with peripheral nystagmus, you know that the pathology is likely in the ear, like vestibular neuronitis. If it's central nystagmus, then we are dealing with central nervous system disorders. And often the central nervous system disorders are more sinister, so more important for you to make diagnosis. So for example, stroke, cerebellitis, brainstem infection, and things of that sort. Okay, so with that, I'm going to end today's dim sum, which was basically introducing central nystagmus to you. I'm going to stay on for another 2 minutes for questions. But for those of you who have no questions, we'll hope to see you at the next dim sum. This evening, I'll be sending to you the video of the bedside tutorial that we managed to do. Very small group, only about two demos were there. And then hopefully, if you have any questions, you can text or email me. Thank you, and keep well. And please have a good holiday tomorrow.
Hi, Prof. Sorry, could I ask a question? Hi, Prof.
Okay, goodbye, guys.
Prof, sorry, can you hear me?
I heard that last week's recording, there was a bit of a disaster. So hopefully this time it's better. Okay. So if you have no questions, I can